Good evening, and thanks for joining us on today's edition of Let's Discuss. My name is Oluchi Amuda, and very with me on the show, as usual, is
Adebare Ejimagde is my name. You're welcome on the program. We shall be deliberating on health-related issues today.
Yes, health-related issues. Diphtheria is what is currently trending in the country at the moment. The outbreak of diphtheria disease, infection, if you put it that way. And we have a guest in the house who will be discussing this with us and also be looking at the health sector generally in Nigeria, the challenges, and what should be done to put it in proper perspective. Yes, my guest this morning is a medical doctor and epidemiologist. He is also the head of department Community Medicine, Junior Osun Teaching Hospital, Osogbo, Dr. Kunle Salami. You're welcome to the program, sir.
You're welcome, madam.
You're welcome on the program.
You're welcome, sir. A good day, our viewers.
Yes, as an epidemiologist, what exactly do you do?
Yes, epidemiologists respond to outbreaks, infections. Actually, there are so many subspecialties of medicine. In clinical medicine, we have the basic medical sciences, we have the clinical sciences. In one of the clinical sciences is community medicine. And in public health or community medicine, there's a subspecialties called epidemiology. Even within epidemiologists, there are clinical epidemiologists, there's a field epidemiology. I am a field epidemiologist. I was trained by Africa Field Epidemiological Network, and Nigeria Center for Disease Control in Abuja, in collaboration with American CDC. So that's where I trained as a field epidemiologist in collaboration again with the University of Ibadan. Thank you.
What is diphtheria disease?
Well, diphtheria disease is actually a communicable disease which is preventable, which it is treatable, and at the same time it is curable. So it is a diphtheria. It is a disease that is caused by an organism, a bacterial organism called Corynebacteria diphtheriae. It is a gram-positive organism, and that is exactly what responsible for diphtheria. I say it is preventable because there's a vaccine for it.
Okay, so the name sounds strange because it's not the usual. Okay, when COVID-19 also came, we started learning about what it is, the prevention, and how to get about it. So, has diphtheria really been around for long, or is it just one of the new outbreaks, infections?
In addition to that, has it gone into an extinction? We've never heard of it until recently.
No. Diphtheria there are some diseases that are referred to emerging diseases. There are some that are referred to re-emerging diseases. Emerging diseases are diseases that you have never seen before, and they are there now. But re-emerging disease, they are diseases that have been taken care of before, that maybe because of improvement in health, we never heard of them before. So diphtheria is more a re-emerging disease. It is not a disease that, though there are so many health workers who, during their training, have never seen a case of diphtheria, but it is not that they've not heard of it. We have had it in the past, but because of improvement in health, most especially immunization, pentavalent immunization that has been given in the past, that has been into our national program, it has been, do I use the word, not completely eradicated, but at least to a certain extent it has been reduced to the barest minimum. So we don't hear of it. It's not a common disease, but we know it.
So what could have triggered its re-emergence?
Yes. What could have, when there's a collapse in immunization, is in vaccination, it could have actually lead to re-emergence of some of these diseases. If there's overcrowding, it could also lead to it, and if the sanitation is poor, it could also lead to re-emerging. It's, in fact, invariably, it is a break when you don't have continuity in health system, positive health system. You could have similar cases like diphtheria. What actually happened in the case that we have in Australia and another part of the country, I learned 4 states have been affected now: Kano, Yobe, Lagos, and Osun State. What really happened is that for those who have been to northern Nigeria before, we know the problem of overcrowding in that place, and it is a droplet infection. So when there is overcrowding and there's a droplet infection, I mean, one is likely to come to have diphtheria. In Australia too, because I spoke with the state epidemiologist and the director of primary health care on this issue, and they told me, I was able to confirm that the child that was confirmed at Elisha, Elisha East local government, was actually not well immunized up to date. The vaccination, he was not vaccinated up to date. So that could have responsible for that. And at the same time, the place I learned is the child lives in an overcrowded environment, and there's you could see the poor sanitation where the child was actually living. I didn't want to really name a particular place so that people will not, put sentiment and all these things to it. So let me just leave that. But at least we know where the child actually lives at Elisha.
So it's just the one case that has been recorded in Osun?
Yes, it is a case, just a single case that has been reported in Osun. But luckily, the case that was reported in Osun actually presented at Elisha, Wesley, and the health workers, I can't say doctor, but the person who actually attended, I can't say whether it's a doctor or, but the person who actually attended suggested that it could be a diphtheria. And luckily, I think it was on 27th of December that the child presented at Wesley Hospital. So sample was taken and it was sent to the National Reference Lab, and the result came back January 10th to be positive of diphtheria. So my appeal to all the health workers is that now there's an outbreak of diphtheria in Nigeria generally, and since there's an outbreak of diphtheria in Nigeria generally, they should be on the outlook if anybody present with fever, chills, and so on and so forth. Or do we go to the symptom straight?
All right. How you trace the origin or emergence of the disease? Is it a disease that is typical of the African countries or beyond?
Yes, it is a disease of it is a worldwide known disease, but more typically in Africa, just because of the fact that I talked about our sanitation, environmental sanitation, I talked about overcrowding and so on and so forth. So it is not typically known, but it's more common with us here. But in tracing, you are talking about contact tracing, or
he's talking about
the origin. How did it come?
Oh, okay. Well,
the first case.
The first case of diphtheria recorded in Nigeria, well, is it's not. There are cases that have been there since centuries. I mean, maybe probably even before independence. It's an age-long disease. And I told you, I mentioned that re-emerging diseases. A re-emerging disease is a disease that was known before, but through treatment and all these things, we don't hear of them again. But if there's a breakdown in immunizations, if there is no proper treatment, they can re-emerge again. So it has been there all along.
So it seems to have gone to extinction before.
Yes,
now re-emerge.
Okay,
yes. You talked about breakdown in immunization.
Yes.
What are the vaccines that a child is supposed to take?
Yes.
Well, at birth, the immunizations of a child actually start from birth.
Okay.
They are expected to take what we call BCG immunization, those ones are to prevent for tuberculosis and so on and so forth. Then the OPV, those ones are to prevent polio.
Okay.
They are for polio. Then we have pentavalent. The pentavalent is actually a mixture of 5 vaccine together in one. Penta means 5.
Okay.
So one of it is diphtheria. Then we have that of the tetanus in it. We have that of a whooping cough in it. Then Haemophilus influenza and so on and so forth. So basically, those are the 5 that we have in the pentavalent vaccine. Then now of recent, HBV has also been introduced.
Okay.
The one to prevent hepatitis.
Okay.
You understand? Has also been introduced too.
So at what age? To what age is a child expected to take the vaccines?
Well, I will not want to say particularly a particular age.
Okay.
Why am I saying that? Because if a child misses some of this vaccine at those recommended age, there is still an opportunity for them to take it.
Why I'm asking this is because when it comes to immunization, the mother has a lot to do.
Yeah.
A child can mix and take later, but in an ideal situation, when you give birth to a child, at what stage to what stage are you expected to? Because on the card there will always be, come back in the next 2 months. What their situation?
Definitely you are correct. At age 0, age 0 means at birth, you take BCG. At 6 weeks, you take pentavalent. At 6 years, you take pentavalent vaccine. Then you take pentavalent vaccine 6 weeks, 10 weeks, 14 weeks. Now, you take hepatitis 2 at 10 weeks and 14 weeks. So, but the last one is the last one that they normally give is vitamin A. Vitamin A is also given at that stage too. So, but as far as the immunization and vaccination is concerned, all those periodic time is there. Then there is one for the measles vaccine too, the prevention for yellow fever vaccine and so on and so forth. They are all there. So when you meet the health workers, they will tell you the appropriate time to come back and the appropriate dose to take. Why am I saying so? Is that for those who missed it, we might, for a reason best known to a doctor after evaluation, might want to say, okay, take so vaccine, take so vaccine. In addition, even a booster dose might also be recommended at a particular stage of vaccination.
Okay.
Yeah.
How available are the vaccines at our health institutions, and who are vulnerable to the disease?
Well, everybody is vulnerable when you are talking about, but vulnerability depends on the disease in which you are talking about, a particular disease. Let's take, for example, now TB. Everybody is vulnerable to TB, but we know that those with poor people of extreme age group, I mean the elderly and the child, those ones are more vulnerable than the other. So we cannot say that a particular age group is vulnerable or one, but one is more vulnerable because it's the extreme ages, they are more vulnerable than those with the real adult age group.
Okay, so when we look at the Nigerian health sector now, we have the issue of the COVID-19 that is coming out with different variants.
Yes.
Lassa fever.
Yes.
These diseases, you know the symptoms. Lassa fever, for instance.
Yeah.
Infected through the rats, right?
Yeah.
Now, how contagious is this diphtheria disease, and how can it be infected?
Yes, the Lassa fever, it is an hemorrhagic disease. I mean, when we say hemorrhagic disease, we are talking about disease that come with hemorrhage, blood, bleeding, blood. It is not rat per se. There's a particular brand, this Mastomia netilensis, That is the rat, the particular rat. We call it, is it mama rat? Yes, call it mama rat. So that is that particular brand of rat that actually leads to Lassa fever. But it's not the rat per se. It is the excreta and the feces, the flea and the urine of the rat that is problematic. If they are contaminated with food and one consumes that, that is when one is likely to have Lassa fever. But let me add to it, there is human-to-human transmission of Lassa fever too.
Okay.
If one is infected and one touches the blood of the person, or there is a exchange of blood of contact without precaution of the blood with somebody who is having Lassa fever already, that particular person too might come down with Lassa. Even the butchers, I mean, some of these hunters and the butchers and so on and so forth that touches the blood of this rat can come down with Lassa fever too. But what is the problem? If you drive on our highway, you will see some of these women preserving cassava flour on the road. Some of these rats comes there to feed on those cassava flour or as a means of preservation, and they get contaminated. The same cassava flour that is contaminated by that rat will be brought from one village to any of the cities to sell. If one is unlucky to eat that kind of food, one might come down with Lassa fever. So it is about environmental sanitation. It is about preservation of our food. So all those things are very, very important. And sensitization, and not only sensitization, passive and active surveillance is equally important. I mean, trying to look for any of those things in the area in which it's common. We are unfortunate. We lost a doctor in Nasarawa not quite long. That we are very, very unfortunate. I think the guy, a gynecologist, operated on the woman because the woman came and bleeding. So they never thought it could be Lassa fever. All what they wanted to do is just to save the woman and save the child. On operating the woman in labor, cesarean section, they got contacted with Lassa fever, and the two of them died. It was after that they now went and took the blood samples and realized that they've contacted Lassa fever from the patient they operated on. So it's unfortunate.
Okay, let's dwell more on the symptoms of this disease, diphtheria.
Yes.
You mentioned one of it, fever, while you were giving advice to the health practitioner. What are the other symptoms?
Okay. Well, most infection generally comes with fever. And then when there is bacterial infection or if there is a viral infection, most of these infections actually cause with fever. And that's why people thought that any fever is malaria. No. When they say Lassa fever, malaria fever, there are so many of those fevers. Typhoid fever and so on. So it's associated with high temperature. But in case of diphtheria, it is a disease that actually affects the upper respiratory tract. What do I mean by upper respiratory tract? From the nose up to the larynx, the pharynx, up to the lungs. That is where it normally affects mostly. So it affects the throat mostly. And how do we recognize? It's important for us to say how we recognized the case of diphtheria. We recognize the case of diphtheria by one, there are what we call gray patches, like a membrane, that you see at the back of the throat if you tell the patient to open his mouth, or maybe you are in your clinic, and you see a gray patches there attached to it's like a membrane attached to the back of the throat. You want to suspect that it is a case of diphtheria. You cannot confirm until there's a laboratory confirmation, but at least you be on the lookout that is likely and take a swab. Other differentials, tonsillitis, there is a gland, there's a structure in our body called tonsil. Inflammation of the tonsil is called tonsillitis. It's also differentials of diphtheria. Then pharynx, pharyngitis, if there's inflammation of the pharynx or there's inflammation of the larynx. So pharyngitis, laryngitis, tonsillitis, all those diseases I've mentioned can be a differential diagnosis of diphtheria. Having said that, what are the other symptoms of diphtheria? I said fever, then difficulties in breathing. There's going to be difficulties in breathing. Then there's going to be swelling of the neck, because the lymph nodes around the neck will be infected. So, and if all those lymph nodes are infected, it's going to be swollen. Then I mentioned difficulty. Then there's what we call hoarseness of breathing. So, in fact, you yourself, you'll be hearing your breathing yourself. So, if it depends on the part of the body it is affected, because when we are talking about diphtheria itself, we have about 5 different types.
Variants of diphtheria.
It's not variant.
Okay.
Is named.
Okay.
Based on the area affected.
Okay.
Then we have the cornea, the diphtheria. Those ones that affect, if it affects the skin, it leads to soreness.
Oh.
Do you understand? Or lesion, sore or lesion of the skin.
Okay.
So that's also another types of it. Then if you check or if you look into if it affects the larynx, diphtheria, pharynx, diphtheria. So depending on the structure, okay, it was given some of those names. So the respiratory system is mostly affected and mostly compromised. Then complications, like it affects the heart and it affects the kidney. It also affects the heart and affects the kidney. And let me say, by way of a microbiologist, that it is a gram-positive organism. I mean, if you take the samples to the lab and to do strains, microscopic screening and MCA, you will see that it is a gram-positive organism. So, as I was saying, it is a disease that affects mostly the upper respiratory tract, the neck, from the nose. So, in fact, there could be nose bleeding, there could be sore throat. There could be sore throat also from it. So, I think I've tried to dwell more on the symptoms. Then, which other, okay.
So, yes, I want to ask, how long can it be in the body before? Because according to the NCDC, about 38 people have died.
Yeah.
How long can it stay in the body before it leads to death?
Okay, well, you are talking about the incubation period.
Yes.
Well, before one could know, but from the times that one is infected to the period in which one is known, it's about 2 to 10 days.
Okay.
That before one could say that's the incubation period. With proper treatment, 1 out of 10 patient dies. Without treatment, 1 out of 2 dies.
Wow. So
the case fertility rate, what do I mean by case fertility rate? The chances of one dying from it is about 5 to 10%. So that's the case fertility rate. But you asked, that's the case fertility rate. You said about 38 people have died. Well, let's talk about how many people are actually infected before we talk about those who have died. From NCDC, as at yesterday, because I still checked, there's no any other release, no any other statistics as at this morning. As at yesterday, about 128 people have been affected, and Out of these 128, 100 of them are from Kano. Then we have some in Lagos, one in Osho, I think about 17 from Yobe State. But those who have died, we are lucky that the only case in Osho State here survived, but about 33 or so have died in Kano. Then maybe some, about 4 or 5 have died in Yobe, and we have lost maybe 2 or 3 in Lagos. Okay. So that makes the 38 figure that we have given. Now, about 128 people have been infected, about 38 people have died from it.
Can the ailment be contacted through consumption of food items or waterborne disease? Is it a waterborne disease or airborne disease?
No, it is not a waterborne disease. It is a droplet infection. It is airborne. So it is a droplet infection. So it is, you released, when they say droplet, I mean something from the word droplet. I mean it is either by coughing, by sneezing, laughing, and so on and so forth, that anybody who has it, the organism could be released. Then if it is released, maybe to any format in the house, clothing materials, even handle of the door or all these things, it could stay there. And if it stay there and one touches, one could. So that is it. It is a disease that one can actually contact it. That's what we call cough etiquette. Do you understand? Cough etiquette. You cough into your handkerchiefs. I learned that from my teachers while in schools. They will excuse you when in class to go and check off and continue to class.
All right, thank you very much, sir.
You're welcome.
Yes, if you just joined us, it is still Let's Discuss on OSBC TV, and we have been talking about the outbreak of diphtheria disease, and our guest has been Dr. Kunle Salami. He's the HOD Community Medicine, Uni Osun Teaching Hospital, Osogbo. Now, doctor, let's look at the health sector in general, Nigeria's response to emergencies. When Ebola came, there were casualties before the health personnel or those the stakeholders started running helter-skelter. Same with COVID-19. Lassa fever is still with us here in the country. And now diphtheria disease. A lot of people, 38 is a lot, have already lost their life. What is our responses like in the health sector?
Well, if I'm to score off our responses to emergencies, I would say good.
Okay.
We might not have been there, but at least we are trying. Why do I say so? Because I'm directly involved. I mean, I've been directly involved. I'm directly involved. When Ebola came, I was at the EOC in Lagos. So we were there. And I and one other doctor from WHO, we were in charge of rumor group, epidemiology, surveillance. Then we have this unit called rumor. So any rumor that is being peddled in any part of the country, okay, I was in charge. And I knew what happened, that in Atlanta that year, after we caught the Ebola in Nigeria here, I'm one of the people that went to Liberia. I was in Liberia then. We were 15 epidemiologists that left Nigeria for Sierra Leone. Immediately we got there, people have been dying, they have been picking cups on the road and all these things. We gave them tips, do it this way, do it that way. Well, we don't know in fact, those people are asking that Nigerians, what magic do they use? So, and everything went there. In fact, that year, Nigeria Center for Disease Control was given an award for being the best FETIP in response in West Africa. Wow. So, because of that, I will not say we are not doing well. I knew what transpired, I knew what happened at the Federal Ministry of Death. People like Professor Nasidi, and so forth, were there at that time. The Minister of Health that time, I've forgotten his name now, the Igbo man, I've forgotten his name. He was an Igbo man.
Osage Hamire. It's still this minister.
No, not Osage. Osage is from Edo. This one, he was the Minister of Health during Ebola period.
Okay.
He more or less relocated to Lagos because we had our EOC at Yaba. Yaba, we are now very close to Yaba Psychiatric Hospital.
Dr. Samegu?
No, okay. It's not. He's a popular man. I think he's in one state university in Eboye there.
Okay.
If I remember, I will tell you. Now, the man partially or totally relocated to Lagos. He will go to Abuja in the morning to go and in the evening to go and do administrative work. The following morning, before you get to EOCs there, you will be asked wondering whether he actually slept in Lagos or he slept in Abuja. The response was perfect, and I'm happy to be part of the success story. So, in terms of response, I will score Nigeria very high. As at that time, later, the NCDC doesn't have a structure. So later on, the NCDC had the structures. It was NFETIP, the Nigerian Field Epidemiology Network, in collaboration with AFINET, African Field Epidemiology Network, which is it was patterned like that of America EIC, American Emergency Disease Response, American CDC in Atlanta. So they are the one that actually brought the program to Nigeria. I was lucky to be part of the people trained by those people. So, and we are the one that they have been using for any of the outbreak. I was there between 2013 and 2014, 15, 16. So I was there. I did the training that time. So the response has been quite impressive. But generally, the health, now that we're having problem of JAPA, our people in the clinical areas are leaving. So, and people are actually trooping out of the country, leaving for greener pastures, which is not really too good for us. Then, if you look at the WHO recommendation, there are 15% of the budget should be spent on health. To me, Nigeria has not met that. I think we are still about 5 or 7%, which is not too good for the country. If we are spent well on health, I think our health system will be more robust than we have. The health problem in Nigeria is beyond the way Labour see it. There is social aspect, the cultural, the social, and all these things aspect of it. What of in a situation whereby there is vaccine, and some people for cultural reasons they say they don't want this vaccine, and lack of absence of taking this vaccine is what is causing problem. The present day Zamfara, where there is insurgency now,
Okay.
I've been there. We went. I was posted to Gumi local government. I went to Madu local government, where they are killing people on almost every penny drop. I went to almost all the villages on those places for this polio vaccination. I was deployed by N-Stop in Abuja that time. So, what of if you now have the vaccine, and some people are now saying they don't want, there is against their cultural belief, or religious belief, or ethnic belief, or whatever belief. That so it is a health problem in this country cannot be solved alone. It has to be holistic. It has to be holistic, the cultural, the social, and so on and so forth. Even poor housing could be a problem for health. But the Nigerian government will encourage them to do more in the area of health. Then, if you are talking about the training of Nigerian doctors, why I used to ask people questions. Why are we in high demands all over the world if you are not well trained? I know the kind of training I had. while in the universities. And I give the glories and whatever I become to my teachers.
The shortage of health personnel
Yeah.
in the health institutions across the country. What's the way out?
What the way out of, because we should not be talking about the numbers now of doctors being produced or health workers being produced. What of the quality?
Okay.
We should not just be talking about the quantity now, or the quality of the people that's been turned out. I can vouch for the people that trained during our own generation that, I mean, a lot of good work was done on us.
What has gone wrong?
Well, a lot has gone wrong. A lot has gone wrong. And I would blame the government largely for that. They've made political office too attractive.
Okay.
Well, it's an area that in which maybe one should not dwell into. But, I mean, as far as I'm concerned, they make it too attractive that even a councillor, and to be a councillor, you don't need to be more than a school cert holder. So if somebody can finally go to secondary school, and those school certs, they are not saying school cert with good grades, so don't say good school cert attempt. So if you have attempted school cert, you can be a councillor. And a councillor, when he gets there, he has more than a professor of medicine. So why do you want a professor of medicine now to concentrate on his work? Somebody that in those days, our uncles and brothers who will come home and start scolding you about your book. I mean, they are the ones who scold us, who tell us, go and carry on, go and do this. And somebody who has not done any, who has not really developed mentally and is doing. So I don't know.
So you're talking about motivation.
Yes,
and remuneration.
yes, you are very
Package.
correct. The motivation should be there. The package should be there. The working environment should be improved upon. How can you say somebody is a consultant and you get there, he doesn't have an office? And a consultant doesn't have an office. How will he do his research? How will he do his work? How will he carry out his own research? How will he do his own work? How will he be? All these things government has to do. There's no motivation in terms of salary, and the other incentives. I mean, so.
Thank you very much, Doctor.
You're
There was
welcome.
a report recently about the collapse of the primary healthcare centers.
Yes.
And the report indicated that it's putting a lot of weight
Yeah.
on the secondary health sector. What's your take on that?
Yes. The primary health care center, the primary health centers, Obasanjo government tried to resuscitate it.
Okay.
And I think, you see, those are the problems that we talk of. Continuity, lack of continuity. I think Obasanjo government that time was trying to resuscitate the primary and make it vibrant. And he said there's going to be one primary care center in each local government in this country, making 774 of it that time. And in each, he said what we call a medical officer of health will be in charge. And the medical officer of health is somebody who has MBBS with MPH. So whatever is happening in that local government, they will be reporting to him. He left. Shortly he left. I don't know what happened to that program again. So if we don't have a vibrant primary health care, honestly, there will be a problem. I was in Liberia when there was a Ebola outbreak. I went to all their villages and I saw the primary health care center they have, despite the fact they said they are poorer than us. Very vibrant and better than what we have here. If you go to the teaching hospital now, even the case that is supposed to have been taken care of at secondary level is being brought to a teaching hospital. Well, I mean, a neurosurgeon, a professor of a pulmonologist treating malaria for what? A neurologist, a neurologist supposed to be doing something better. You are bringing a case of malaria to him to treat. Well, when you can go to a primary health care center or at most a general hospital, and you'll be taken care of them. But what is the problem? The primary health care is, I think, is under the local government also. The secondary is under the state, and the tertiary, the teaching hospital, is under the federal government. So most of these secondary health centers, they don't have personnel, adequate personnel, because they'll be talking about the wage bill. So because of the wage bill, most of them are dodging recruiting people into the secondary health care. So it now put pressures on the tertiary health care, and that is the problem we're having.
Okay, stay on diphtheria disease.
Yes, sir.
How do we curb the spread in the country now that it has re-emerged across the country? How do we surmount the challenges now? What are the necessary measures to be put in place to checkmate the spread and the disease?
Well, very simple. Very simple. What do we do to checkmate diphtheria that's rampaging the country? Let me start with what happened in Osun. A retroactive case search and active case search was actually done. They've actually gone contact tracing.
Okay.
They listed all the people that child might have had contact with, and they follow up with the maximum incubation period of that disease. Twice, because the maximum incubation period of that disease, to see whether those people who had contact with her will come down with the disease. But luckily, I think maybe nobody had come down. Then, the retroactive, they are going to the past, all the people she had contact with. Then active case search, they listed and they are following up people. Now, the child was not well adequately immunized, so they are giving immunization they will give immunization to make sure that we improve on our vaccination generally, both the routine, both our routine vaccination program. Then I talked about, I said it's a droplet infection. So because I said it's a droplet infection, we have to improve on our personal hygiene, sanitary. Yes, very, very important. In a place like Kano, where the disease actually broke out, if you have been there, the housing code or the way the houses were being built in those places, you will see that ventilation. I mean, I'm not saying the whole Kano anyway, because but I'm talking of where people like me, where the less privileged people stay. There are places in which some of those houses does not even have window. They don't. If you have entered, you enter through the main door. You enter through the main door, then is this Kunle part of the house, so that you know the age long and you know the cultural. We had it here before too. The Yoruba people call it Ile Mayashano.
Okay.
Yes. And why are they doing that? They are doing that to protect our women. You know,
Okay.
So yes, so that's the cultural way of building a house there, to prevent adultery among the women, to prevent fornications among the young ones. So basically, those are the major reasons why those building patterns were still there among the less privileged. I'm not talking about the well-educated people there, and that is what is actually led to the problem, or part of what is actually causing the problem. Because a droplet, if you cough into an open place, the place is well ventilated. It's loud, on lands and all this. It's not going to cause problem for anybody. But in a situation wherever you cough, and there's no ventilation, you are coughing directly to another person's mouth. Another person is likely to get it. So improve on hygiene, improve on immunization schedule, our routine immunization schedule, then the campaign, and so on and so forth. Then engage the stakeholders. If it is the religious leaders that are important, there are some people we listen to. Talk to them. If it is the traditional rulers or the people they are going to listen to, so engage the stakeholders so that people will take this vaccine. I knew in Kano or some part of northern Nigeria before when polio first came. Part of the problem some people had was that they were saying that it was to reduce their population, it is to cause infertility amongst them, so that they will become infertile and they will not be able to reproduce again. I knew some health workers were actually attacked. Some health workers were actually attacked in some states in this country before. Not only attacked, they were killed.
Wow.
Just because they went there to give them vaccine.
So there's need for sensitization.
Yes, there's need for sensitization. There's need for community engagement. There's need for to engage all the opinion leaders. Opinion leaders generally Oba, Emir, Alagwas, the Bales, the religious leaders, Imam, the pastors, and so on and so forth. Let the Oba comes out, let the Emir comes out. Take that vaccine in their presence. Let him give it to his own children or to his own grandchildren in their presence, so that the leadership by example, they will be able to follow.
Thank you very much, Doctor. Let me quickly ask this. You talked about some health workers that had they were exposed to a lot of hazards in the course of doing their job. Now let's look at the risk involved with the job of a health worker. What are the risks? What are the hazards of the job? Because most of the time you have a doctor that died and because of treating an Ebola patient then and all that. So let's talk about the risk. Yes.
If you want to break down the risk of health workers, it actually depends. Funny enough, the hazard allowance of a doctor is 5,000 naira. It's unheard of that with all the hazard we are being exposed to, our hazard allowance is just 5,000 naira. It's just of recent that they said they've increased it in proportion, and I think maybe 20,000, 30,000. They have not even started. They've not even started implementing that anyway. But they promise paying that. I've seen the paper anyway, but I've not seen the money.
All right.
The hazards that we are exposed to are many. Let me take it unit by unit. Somebody who works as a radiologist, sonographers and so on and so forth, they are exposed to high radiations. And I want to mention names. I've seen a friend who came down with leukemia, lymphoma, leukemia, and he died. A consultant radiologist. I won't mention the place, and I won't mention but it's a friend. Now, we have seen a situation where doctors were operating on a patient and needle prick on HIV patient, or even of recent hepatitis. Now, coming down with HIV later and coming down with PLCC, primary liver cell carcinoma, as sort of being exposed to hepatitis. We have seen cases of doctors working, or not even doctors, only doctors now, health workers, working in the hospital, and the course of his work had Ebola. And you know Ebola is an hemorrhagic, not Lassa, which is more common here with us. It's an hemorrhagic disease. Start bleeding from the orifice, from the nose, from everywhere, and then the patient died. Now, those of us who are the field workers, someone like me who are an epidemiologist who goes to the community and all these things. We have seen situation of workers health workers being attacked on the feet during the course of doing their work. Let me tell you what I did when I went to Safara.
Okay.
2014. If you see me on the feed, actually you can't recognize me because I disguised. I had this jalabia, this normal jalabia that everybody wears. It was, I don't wash it for that 1 week, so dirty. And it was intentional.
Okay.
So before you will know that I'm a stranger, I would have gone. If you have seen me, you can never know I'm a stranger. Except I stay with you 3 or 5 minutes. Before you know that, I would have gone. What do I do? If you enter a place, we have a local guide. It is that local guide who is mobile, who goes with a bike. Okay. Is the one that takes us to the interior of all the interiors. In fact, if you are born in that local government, where I will go, you might have not have been there. Because there's places we call out to reach area. That some places we have to cross river. Some places we have to use donkey. Okay. Some places we have to use camel to get there. Some places we have to use canoe to get there. So, but people don't know all some of these things that we face or defeat. And let me tell you a funny one that happened or I experienced personally. I went to one local government in Plateau State. When I got there, I've done all my work on our way coming. My local guy, one old man, now saw the local guy, and he was talking to my local guide in their dialect that we should leave. That the traditionalists have gone to the place where they are doing their worship. That if they are coming, they must not see us. That if they see us, they will think it's an impersonation. So I told the guy we left. So I now asked that if they see you, what will happen? I don't know whether it is true or it is not true. They said that those people will take somebody's manhood and one will be infertile for life. Or very funny. But it wasn't funny that day. As I'm reporting or as I'm sharing with you now, it looks funny. But that's exactly, I didn't want to mention the particular place. So when I got there, they now said that to appease them, I have to buy, seven goats? Okay. Then 7 gallons of palm oil and so on and so forth. All right. But luckily, we did not. If I mention the local government, one of the former chief of defense staff was the Oba of that local government. Let me just. All right, Dr. Salami. Okay. Because of our time. Yes. Because of our time. Your final address to the people at home on diphtheria. Exactly. Does the state of individual's body immunity has any link with the infection?
Yes, in addition to that, as a parting shot, so also wanted to advise the mothers, because when it comes to immunizations, women are 100% involved. Okay. Advise them. Yes, diphtheria in Yoruba is called bofun bofun. Bofun bofun. And that is why I told you that it is not a disease that we don't know before. It is known. So it's bofun bofun. Let me appeal to our mother to please not to take immunization with levity, to take it very serious. And it is not only the mothers that I'm going to appeal to now. Let me appeal to the father too. Because if the mother is ready to take the child for immunization, the father has to provide the transport fare for the mother to go. So the father too. So please be a supporting father. Not only when the child is successful that you want to come out and start showing us that you are the father. Being a responsible and a supporting father right from even before conception, right from the time of pregnancy, right from the time when the child was born, and right when the child is actually growing up. So it is very, very important that we take our head
It's very, very serious. Then the immunity, it also actually has an effect. Let's eat well, take fruit, relax well, and lives in a very conducive and in a very good environment. Thank you very much.
All right. We have to put an end to this presentation at this juncture. Special thanks to our guest, Dr. Kunle Salami from Union Teaching Hospital. We're glad to have you on the program. And this is the parting point on the program. We also employ viewers to make sure that they always take their health very important and observe personal hygiene guidelines towards promoting a healthy living. I'm Adibari Jumakide.
Yes, I'm from Olucham. I'm saying health is wealth and prevention is cheaper. It's cheaper and better than cure. So stay healthy, live healthy. Thank you very much, Doctor, for making this program.
Thank you.
Bye for now.
Thank you.